Thank you, sir. Thank you, Apollo Hospitals and ISCCM for giving me this opportunity. We'll be starting with our session. The topic is the art of monitoring a critically ill patients in ICU by the nurses. So caring is a high technology driven critical care environment is fast paced, directed towards the monitoring and treating a life threatening conditions, which in terms helps in the patient good outcome. The critical care nurse must be able to deliver high quality care skillfully using all appropriate technology. Next slide. So what are the basic principles of critical care nursing? Just is anticipation, that means foreseeing. The moment we assess the patient, when we go to the patient bedside, the complete assessment will give us the many inputs related to the patient care. One has to recognize the high-risk patients and anticipate the requirements. The critical care nurse must be prepared to meet any emergency, and our unit should be properly organized to meet all emergency needs in the critical care units. Early detection and prompt action. The prognosis of patient depends on early detection of variation, which directly depends on the nurse who is dealing with the patient, because we are available 24/7 at the patient bedside. It is our prime responsibility to assess the patient and understand and early detection and prompt action. Next slide. Before slide. So this is one glimpse of photo how an ICU patient looked like. If you see a patient on ECMO machine, on ventilator, multiple syringe pumps connected to the defibrillator. So it is not an easy task for the critical care unit, whether it is a doctor or the nurse or anyone dealing with the patients, should have multiple focus on each parameter assessment, starting from the monitor to the ventilator. What are the parameters we have to see in the monitor? What are the things we have to assess? When the syringe pump is there, infusion pump is there, what are the things going into the pump? What is the drug going? What is the concentration? What is the flow? Where it is connected? Each parameter is very critical in and critically patients to identify the problem, to anticipate and to prevent. This helps in a good critical patient's outcome. Next slide. So assessment of patients and planning for patient care. The three primary things which we have to remember is know, see and find. You have to know the medical history of the patient, complete medical history, what is the treatment going on for the patient, and see for the airway patency at one look. Airway patency, any pallor, any sweating, what is the mental state of the patient, what is the general condition of the patient. Then find for any deviation from the regular general assessment, like what is the respiratory rate, our vital parameters, what is the saturation, what is the output, what is the blood pressure, what is the conscious level, and how we have to monitor each of these things is a part of our nursing regular care at the patient in ICU. Next slide. So what is our initial approach to the patient? If the patient is good, conscious enough and his GCS is 15/15, have a verbal response to the patient, talk with the patient, assess the patient airway, the same thing. We have to start from ABCD, assess the airway, breathing, circulation. It's clearly reflecting in the slide. We have to assess for the airway, then the breathing, then see the patient speaking, whether slowly, any distress, then any failure to respond for any one of your parameter, you can easily identify by your complete assessment. Next slide. So what is ABCDE approach? We have to follow a systematic approach. We have been studying in our nursing basics from the BSc nursing or the general nursing. We know what is a systemic approach, systemic assessment, because we used to write our nurses note, nursing care plan, our case presentation shows these presentations. So starts from the airway, goes to the breathing, then assess the circulation, then see for any disability and expose the patient at least the overall condition of the patient. Then always treat life-threatening problems first. Then this will enable assessment. We have to instigate the monitoring, have a IV access, good patent, and ensure effective communication. If needed, we have to call for help immediately. Next slide. So when we come to general appearance of the patient and vitals and monitoring, the moment we go to the patient, we have to see the cardiac output monitor, which is cardiac monitor connected to the patient. See the vitals parameter. It may be heart rate, respiration, blood pressure, saturation, ECG. So when you go for ECG, check the rhythm in the monitor. Along with, you have to check the leads placement, because if there is a little loose connection of the lead placements, also the graph will change. So that in itself gives a wrong impression to a doctor, whoever says that patient may be having some ECG rhythm disturbances. So before going ahead and identifying, we have to identify the connection, because all this has been equipment derived. So when we rely on equipment, we have to cross check whether everything is connected properly as it is indicated. Then continuous blood pressure. It may be invasive or non-invasive. When we go for invasive, it is arterial blood pressure. Then if it is non-invasive, it is our manual blood pressure, which will be monitoring. Next slide. So we'll just come with a focused assessment from head to toe. We'll start from head, like neurological examination includes GCS, respiratory. We have to consider the airway if the patient is on ET tube, etc. Tracheostomy. Circulation, you check for the blood pressure and the pulses. Abdomen, if the patient, about the nutrition, about the genitourinary system, about the output, any pressure ulcers. Then upper and lower limbs for the movements, and check for any drain, any lines, any source of DVT, any source of infection, etc. Next slide. So some glimpses of the respiratory cardio, I'll just read out. Respiratory, when we, what are the things we have to see? Is there any airway obstruction? Is the ventilation is happening properly? Is poor secretion clearance is there for the patient? So if you see these type of things, what is the basic management as a routine nursing care we have to do? So we have to assess the patient in coughing. If the patient is not conscious on ventilator, do a suction whenever required. Then deep breathing and chest percussion, you can take the help of respiratory therapist or the physiotherapist. Then following a position, suctioning, and if necessary, as I've said, if it is an endotracheal tube, it is endotracheal suctioning. If it's a tracheostomy, we have to do a tracheostomy suctioning. Then comes to cardiovascular. Cardiovascular, if the prolonged immobility impairs the autonomic vasomotor responses, you have sitting and standing causing profound postural hypotension. Prolonged immobility may lead to DVT. Not only that, the chances of P is also high. So we have to enable the patient with the help of physiotherapist and the consultant orders as early as to mobilize the patient and have a DVT prophylaxis in place to prevent deep vein thrombosis. Then comes to gastrointestinal or the nutrition. As we all know, nutrition plays an important role. As we always say, food is a medicine as a part of treatment. So we have to position the patient properly, follow the doctor orders, give the feedings properly if the patient is on trials, to follow the process and the policy in place of the trials to prevent the aspiration. If it is a oral diet, ensuring that patient is getting the appropriate kilocalories of the diet as mentioned. Next slide. So as I have said, we'll start with the head to toe. So when it comes to the CNS, central nervous system, the important parameter as a nurse is to assess GCS every area in an ICU. GCS stands for Glasgow Coma Scale. So we have eye response, motor response, verbal response. Each one of us know what is an eye response, what is motor, what is verbal response. We know the scale because it is a book picture for us. And we should know, we should able to understand what is the score. It is 15 by 15. If you calculate each score, 4 plus 6 plus 5, it is 15. The 15 by 15 score is a normal score for any patients. So in the ICU, how we have to monitor? The second picture in my slide shows Glasgow Coma Scale EVM. E stands for eye opening, 4, V stands for verbal, M for motor. So by using those scorings, we have to document. If you feel there is a decrease in the score, like in this hour we have scored the patient as 15 by 15, like he was very well alert, conscious, oriented, talking, and suddenly in the next hour you saw there is a drop in the GCS. It may be 13, 14 or 12. The primary responsibility of the nurse to assess the patient, understand why there is a drop, immediately inform to the doctor concerned so that we can rectify the problem, we can anticipate the problem. The drop in GCS may be, for example, patient may be having a sudden chances of stroke. So we have to identify. Identification is in our hands. As I have mentioned, 24/7. We are observing the patient every minute and every hour. So this is the important role of GCS. Next slide. Assessment of circulation. As I have said, cardiovascular, central nervous system. Then comes to the circulation. We have to check for the cardiac output by measuring the blood pressure. It may be invasive, non-invasive. Check for the patient urine output. Check for any bleeding. If the patient is having any drain, it may be a post-surgical patient to whom we have received immediately from the surgery. Otherwise, a post-traumatic patient who had a RTA with multiple injuries and is having a massive bleeding. For that cases, we have to continuously assess the circulation to see whether there is a drop in the BP, drop in the urine output, and escalate those issues immediately so that hypotension can be treated before he goes into a shock. Next slide. So other than those systemic approach of a patient, when we are in the ICU, we do assess the patient systemic approach. We do document, as I said, past medical history, current medical history, surgical history, everything we do follow. But when we go to the patient bedside, what are the main focus thing when the patient is connected to the multiple equipments, as I've told in my first slide, with the multiple syringe pumps, ventilator, oxygen, fluids. So there are some specific things which we have to see. When it comes to the monitor, as I mentioned, check the connections to the cardiac monitor, check chest slit placement on the patient, right, left, etc. Then check for the set alarm rates. Why I'm telling this? Because if the patient is with the AF, the heart rate will be little higher, like tachycardia, it may be 150 or 140. Continuously monitor gives alarm. So we should never neglect. First, we have to identify, diagnose the patient. If really an AF, then with the permission of the doctor, we can set the alarm rates. Then adjust the scale as per the patient readings. If you see our scale, if it's looking shorter or the longer, the ECG rhythm understanding and diagnosis is little tricky one. So we have to adjust the scale of the rhythms according to the patient heart rate. Then if the patient is on NIBP, do check the interval of cuff inflate time. As I have said, it is a machine-driven ICUs nowadays. So NIBP can be set for every 5 minutes or 15 minutes, where it will inflate and deflate to read the BP. It doesn't mean that every 5 minutes you need to record the BP, because if it is every 5 minutes, there is a chances that patient may have a skin injury over there. It is called a pressure injury. So we have to check that also. Then when it comes to the oxygen, check whether the patient is going with the correct amount of prescribed oxygen. It may be 2 liters or the flow liters. Check the flow meter, whether it is connected properly to the humidifier. Check for the flow from the connector to the patient. Then check whether the patient required the humidifier oxygen or not. Why we have to give the humidification oxygen? We all know that oxygen creates a dryness. It in turn goes into your bleeding. So then monitor the SpO2 level and document in the nurse's notes. Then we go to the patient bedside, we check the fluid, check for the rate of the fluid, whether as per the doctor order it is going or not. And see the label, whether the correct ml has been going on. If it is 100 ml started at 10 a.m. in the morning, if it is for only 5 hours, 10 a.m. to 10 p.m. there is too much time, it is 10 hours, where we have to complete in 5 hours. So these are the things plays an important role in treating a patient, because patient on NBM, otherwise patient is on hypovolemic shock, decreased urine output. So fluid intake for those patient is very much important compared to other patient who is on diet. So these things, labeling the fluid, understanding what rate it is going, calculating the drop rate, plays a vital role for these patients to prevent hypovolemic shock or hypotension. Then before starting the IV fluids, as we all know, as a thumb rule, we have to prime the IV set to clear any airlocks. Then watch for the site for any phlebitis or infection. And as we all know, IV set is a single use. If it is crossing 24 hours, that IV set need to be discarded and changed to the new set. Next slide. Before slide. Yeah. Now we have completed with the monitor, fluid, oxygen, and this is something related to the lines. So lines may be multiple. Some patient may have a carotid line into the internal jugular, otherwise subclavian or the femoral, or the dialysis catheter, or the arterial line. Arterial line may be again femoral artery or the radial artery. Whichever line it is, the mechanism of taking care, preventing infection, monitoring is the same. So when it comes to arterial line or the central line, those lines need to be maintained with some amount of pressure to prevent line blockage from the clot. The first picture shows the pressure bag, and the pressure manometer shows it should be maintained up to 300 mm of Hg pressure, so that every hourly 3 ml per hour flush will be going to the line without you going and flushing. It is a automated thing. The moment you put the pressure bag with the pressure of 300 mm of Hg, automatically every hourly the ml will be flushed into the line. It in turn prevent the clot into the line. It may be, again I'm telling, it may be central line or the arterial line. Okay. Then you have to monitor the patient for any signs of complications like hematoma, bleeding, signs of infection. Then label all lines with the date of incision and the day, because as early we have to remove the lines. If not in use, flush the lines. which helps in prevent the clotting. Sterile dressing, which is a transparent, so that we can view the line continuously, ensuring all connections are fit enough without any dislodgement. So if you can see the third picture in the slide, there are multiple connectors to the patient, multiple infusions patient is getting. So each infusion should have a label on that. Check whether stop lock is properly opened. It doesn't mean that we connect and we put the stop lock in a wrong way. We have to check the moment we connect, starting from the pump to the patient line to the central line, whether it is connected properly, tightly, there is no leak, there is no air. Then open the clock, stop lock very clearly, checking the flow that it is going into the patient blood system into the lines. Then all medication connected in the line must be labeled with the name of the drug, and must check the lines for any loose connections. By seeing that, you can understand, is there any loose connection, is there any leakage, is there any backflow. And the one more thing, the new the blue color cloth which you are seeing in the central line, near to the central line, is a drape cloth which is a sterile one. Why we are using? Because the moment you connect all these lines, it is all sterile, and you are putting near on the bed, it may be pillow or the bed sheet, so it is unsterile. There are chances of infection to the patients is more. To prevent that, we have to use a sterile drape cloth to cover all infusions. And even this also, when you are covering, you have to see that flow is going properly, there is no loose connection, there is no backflow, there is no leakage, all connectors has been labeled properly, because we are closing, ensuring that everything is in place 100%, then only we are putting the sterile drape onto the line. Next slide, thank you. Next slide. Then comes to the lines. It is like femoral artery line. This one picture shows femoral artery line. Our extension to the lines are too big. So it doesn't mean that much big line we may require, because when you are turning the patient, we require a lengthy line. So when it is a lengthy, we have to ensure that it is not folding anywhere, kinking anywhere. Put it a circle, put a plaster, so that we are not going to kink the line. There is no accidental removal of the line. Okay. Monitor all lines inserted at site for any signs of redness or hematoma. If yes, inform the doctor and follow instructions. Secure extra length of connection, as I said, with a plaster. All lines should have a sterile, transparent dressing to see the site for any signs of infection, redness, etc. Then the third picture in my slide says the CLAPC maintenance bundle. It is central line associated bloodstream infection prevention bundle. So this will be done every day in each shift by the concerned nurse. I'll just read out the parameters for each line. Whenever you're touching the patient, hand hygiene is the primary thing we have to follow. Hand hygiene, we always know the 6 steps of hand washing and the 5 moments of hand hygiene. So each bundle says we have to follow the hand hygiene. Then you should know the need of the line and review whether it is necessary or not. Talk with the doctor, understand the need for the patient line, and check whether the dressing is intact. If it is soiled, change the dressing. If not, we can leave the dressing. It is not mandatory that every day we have to change the dressing. If the dressing is intact, no soakage, it is looking good, sterile, then no need to change the dressing. Then we have to use chlorhexidine gluconate 2% to clean the area for any change of dressing. Then alcohol hub decontamination for each time when you open the port to give any medication or blood sampling, to connect anything, we have to clean with the alcohol rub. Then you have to give the injections. Next slide. This is about if the patient is on central line, we are following central CLBSA bundle, as I have said. If it is a peripheral line, just you have to say, secure the line properly with the date and time, assess the line for any signs of phlebitis. If you see any signs of phlebitis, change the peripheral catheter. Next slide. We have done with the CLBSA bundle as a part of important things to the line. Now we are coming to the Foley's catheter. Many patients in the critical area will be on the Foley's catheter and urinary catheter to monitor the intake and output, because output plays an important role in understanding the patient kidney function. So when there is a Foley's catheter, first you know the indication of the Foley's catheter, why it was inserted for the urinary catheterization. Then monitor the output as needed. Follow COTI maintenance bundle, as the next picture says the COTI maintenance bundle. Document the date and day of the catheter. Any line, any tube, any drain, you should know the indication why it is there. On the particular tube or the drain, you should have a date and time when it was kept, what is the day. So now we come to the maintenance bundle. As I've said, CLBSA bundle, any bundle, hand washing. Again, I'm repeating, hand washing of 6 steps and 5 moments of hand hygiene important in preventing all types of infection in any ICUs or the wards in the hospital. When it comes to the potty bundle, catheter associated urinary tract infection maintenance bundle. So hand hygiene is the first thing. Then assessment of need for the urinary catheter. As I have said, whether that is required for the patient or not, it is our responsibility to understand, talk with the doctor and know. Then catheter care is given or not. In each shift, the catheter care to be given. Urinary catheter has been continuously connected to the bag. There is no kinks to prevent the tube, blockage in the tube. If there is a kink, maybe after 2 hours or 1 hour you fail to see, but after in the third hour, you'll see that there is a drop in output. So suddenly we go and tell that patient is not having the output. Before going ahead and informing, please check properly whether the tube is connected to the continuous flow without any kinks into the patient. It may be patient below the patient backside, otherwise the patient thigh, patient knees, patient legs, anywhere the tube Foley's catheter connection can be kinked. So we have to make sure that there is no kinks into the Foley's catheter and it is continuously connected to the sterile drainage system. Then urobag is to be kept below the bladder level. As we all know, the bag cannot be kept near to the patient waist level. It should be below the bladder level so that urine output can be easily collected into the bag. Next slide. Then fast tug. The one of the bundle parameter for all ICU cases. Now I have told about the central line, ventilator and the potty bundle. Apart from this, there is something, if you follow this fast tug bit, we can tell the doctor, identify whether patient, are we missing anything for this patient. Example, we'll start with the F of feeding. Understand why feeding is important is to prevent the peptic ulcer peptic ulcer diseases. So know the reason if the patient is on NBM, why he is on NBM. If NBM is a patient is on any antacids. Then comes to the analgesia. Many patients in the critical areas like ICUs, they will be having mild to moderate pain. It doesn't mean that they will not have, because multiple lines, multiple tubes. So they should be placed on some doses of analgesia medications. Then comes to the sedation. As I said, any patient with the ventilator or post-operative major surgical cases, they will be on some sedation. So we have to monitor those patients on sedation. Then comes to the thromboprophylaxis. As I have mentioned in the cardiovascular system, prolonged immobility. Patient is bed-bound. We are not mobilizing the patient every shift, not in every day also, because with those ventilators, we cannot mobilize the patient. If the patient is on ECMO, we cannot mobilize. If the patient is on massive bleed, we cannot mobilize. If the patient is on multi-doses of inotropes, hypotension, on dialysis, those patients we cannot, there is no chance of mobilization. In this thromboprophylaxis, there are two types. One is chemical and mechanical. When it comes to mechanical, it is like our stockings or DVT or SCD, sequential compressing devices. Those are those stockings which will put from the outside, but it will give a compression to the patient muscles in preventing the clotting. Because this will be applicable when you are unable to keep the chemical prophylaxis. Chemical prophylaxis means are drugs like Lexin, Fracmin, heparin. All the patients in ICU may not be indicated with these chemical prophylaxis. So, like example, I have said, when the patient is having a profuse bleeding, these prophylaxis cannot be taken up. So we have to go ahead with the mechanical by using the SCD sleeves, otherwise our regular stockings to prevent the DVT. Then head of the bed elevation. Unless it is contraindicated for each patient, head end to be elevated to prevent aspiration. The contraindication, as we all know, it is only applicable for a patient with a head injury or the cervical vertebral fractures. So unless it is contraindicated, and if the doctors are telling there is no, this patient need to be not to be head end elevated, then for those patients it can be excluded. Other than that, there is no excuse for any one of us to make the patient to sleep supine on the bed. Any patient, the moment we see in the ICU, should have a head end of the bed to be elevated. Then ulcer prophylaxis, then glucose control. As we already know, glucose control, controlling the glucose in our body, it helps in good outcome of the patient. Then spontaneous breathing trial is applicable when the patient is on ventilator. As we already know that early detection, daily review, early removal, and the spontaneous breathing trial is something when the patient is on ventilator, we have to assess to stop the sedation, assess whether the patient is able to take his own breaths, whether he is syncing with the ventilator or not. The trial need to be given. This is a component of our ventilator bundle says sedation and vacation. It means that we are stopping sedation for some time and waking up the patient to see how much far he is able to breathe, because we are suppressing his respiratory muscles by completing support with the ventilator. So this is important parameter to understand when the patient is on ventilator. Bowel care. When the patient is on ICU, as I've said, feeding will be compromised. Patient is not mobilized. So we have to see whether patient is having any incontinence or the constipation. So if the patient is not passing motion for 3 days or the 2 days, inform the doctor, have the follow the doctor instructions. Then see indwelling catheter removal. As again I'm telling, our bundle says daily review and early removal. Why we have to remove early when it is not indicated? To prevent infection. De-escalation of antibiotics. If it is required, the antibiotics will be going on. But if the patient is not requiring any type of antibiotics, it is our responsibility to remind the doctor, sir, this is day 5 of antibiotic, this is day 6 of antibiotics. So is there any culture reports awaited? If the culture report is no growth, then you have to remind the doctor, sir, report is so and so, there is no growth. So then you are giving a inputs to the doctor in taking a decision into the patient care whether we can escalate the antibiotics or not. So this is a type of checklist where we will be filling into the ICU. The same thing fast track will made into a checklist where we can just cross check and tick mark whether that is happening with this particular patient or not. Next slide. So pain. In our fast track I have tell analgesia, sedation. So how we will identify a patient when the patient is on ventilator, when the patient is on sedation, where he is unable to verbalize. As we all know, visual analog scale, it is from 0 to 10. So I'm not going into detail with those scale. If it is 0 to 3, it is mild, 4 to 6, moderate, and the severe. So when it is mild to moderate, we can intervene so that patient will not land up into the severe pain score. So to the second scale, which I'm showing, is a behavioral pain scale. This is applicable for the patient who cannot verbally communicate, to whom we have to assess the pain by using behavioral pain scale. So what are the parameters we have to assess in behavioral pain scale? One is facial expressions, in which what we have to see, whether it is relaxed, whether it is tightened and fully tightened, and grimacing. See, by seeing our facial expressions, even if you are conscious also, our facial expressions can easily identify, other person can read whether we are with the pain or not. Because the above visual analog picture you can see, when the patient is having severe pain, patient face is in red color. So the facial expressions, by seeing those, imagining, we can understand whether his patient is having the pain or not. Then upper limbs. If there is no movement, patient is comfortable. If the partially bent, it is to fully bent with the finger flexion 3, permanently retracted 4. So the moment the score is coming up, like if it is 1, it's okay. Like then the score we have to calculate. Then compliance with the ventilator. If it is tolerating movement, that means he's not having any pain, he's comfortable. Coughing but tolerating ventilation of most of the time, you have to score 2. Fighting with the ventilator. When the moment we see patient fighting with the ventilator, not syncing with the patient ventilator modes, then we have to understand there is some problem where patient is struggling. Then unable to control the ventilation. Continuously in the ventilator, we can see peak is going up, patient is coughing continuously, there are so many secretions, he is trying to bite the tube. So these are the parameters by which you can understand whether patient is in pain or not. The maximum score is 12. We have to score this behavioral pain scale by 3 by 12. 3 is normal, 12 is the maximum. So as I have said, facial expression relaxed 1, upper limbs no movement 1, compliance with the ventilator 1. 1 means patient is in relaxed mode, he is not having any pain. The moment the number is increasing, that means patient is having some sort of pain where we have to identify, inform the doctor, then take the necessary action to control the pain of the patient. It is important to understand that whether patient is having pain by using these scales. And the 3 and 4 is for the pediatrics and the neonates. For the neonates, we have a NIPS, neonatal infant pain scale. And the pediatric, it is a flag scale. Next slide. And the fall risk assessment and intervention, it is not particularly to the ICUs, it is even for the wards also. We have to have a fall risk assessment to understand whether patient is vulnerable at the fall or not. All ICU patients at risk of the fall. So what we have to do? We have to follow the fall intervention checklist. The first picture in my slide shows the consent which we have to take from the patient and family. If the patient is unable to give, we have to take from the family that we have educated about the fall prevention measures and what are the things we are following at our hospital. Second thing is modified Morse fall risk assessment. What we are doing, how we are assessing to understand whether patient is at risk of fall. And third one is fall intervention checklist. I'm not going in depth of the assessment, but I will just read out what are the interventions specific to the high risk patients. So we have to put always side rails of move all lock all movable equipments, adequate lighting, orient the patient to the room so that he will not touch whichever is nearby him, place articles within reach of the patient, position bed always lower, tease the patient what to do, what not to do, educate the patient and family, help the patient in the toilet needs, give the physiotherapy consultation, continuously visit the patient, inform the housekeeping person for those type of patient when we are mobilizing. The pathway should be clear and it should be clear. It should not be wet floor. Next slide. Pressure ulcer risk assessment. As I have said, the moment we go for cardiovascular system, decreased cardiac output, hypotension, DVT, there is a chances of long-term immobility on the bed may cause the pressure injury also. So the first picture says Braden pressure ulcer risk assessment. It is for HAPU to understand at what risk patient is it, whether he is at the risk of developing a pressure ulcer or not. So what are the parameters which will just assess? I'll just read out. One is on sensory perception, on moisture, activity, mobility, nutrition, friction and shear. According to those parameters, we'll score patient from 4 to 1. So in this scale, it is little bit of up and down. If the score is high, patient is at less risk of the pressure ulcer development. If the score is less, patient is at high risk of getting pressure ulcers. The picture 2 shows the gradings of the pressure ulcer as we already know, grade 1 to grade 4. I'll just read out what are the prevention parameters which we have to follow for the pressure injury prevention. We have to see suitable support surfaces. It may be alpha bed, nimbus bed or the water bed. Then keep repositioning. As a mandatory, we have to follow position clock saying that every second hourly patient need to be turned. Like at 10 a.m. you're putting the patient in supine position. At 12 p.m. make the patient turn into the left lateral. At 2 p.m. to the right lateral. This is a position clock which you follow so that we can reduce the risk of pressure injury to the patient. Incontinence care, if the patient is on male cath, otherwise patient is having the bedwetting, have a frequent visit, turn the patient continuously, make sure that patient genital area is dry. Then nutrition and hydration, as I have told, nutrition is a type of medicine to the patient. It helps in good outcome. Good nutrition helps in reducing the risk of pressure ulcer. Check medical devices. As I have showed in the picture, many medical devices connected. Some may be into our back, some may be onto the legs, hands, limbs. So you have to make sure that there is no pressure associated because of that device. Because the moment the device is underneath our body, the chances of rubbing friction increases and the patient will have start developing the pressure injury. Then assess the risk and skin regularly, reduce the head of the, then elevate the heels. Next slide. As I have been telling from my first slide, nutrition plays important role, feeding, because feeding of the patient completely, again, we are taking care of the patient. If the patient is on oral diet, we are feeding the patient. If the patient is on enteral, whether it is a rice tube or the intravenous TPN also, parenteral nutrition also, we will be administering everything to the patient like a medication. So the routes of enteral feeding may be nasogastric tube feeding. It may be a tube through the nose into the stomach, nasoduodenal or the nasojejunal. So nasogastric feed, as we always know, and we have to take care of the patients. When the patient is on the nasogastric feed, we have to elevate the bed and aspirate, check the feeding position. Next slide. So it is a continuation. We have to auscultate over the stomach after injecting air via the tube to confirm the tube position in the stomach. Why we have to? Because if the tube knot is in the stomach, we are going to give the feed into the wrong area where the patient may land up in the aspiration. So you are giving directly feed into the lungs. So we have to confirm the position of the tube. The best way is to take the X-ray and confirm the position, and also aspirating the gastric contents. Aspiration of the gastric contents should be undertaken every 4 to 8 hours as per, and it depends as per the hospital, because as per the new guidelines, it is not mandatory that every feed we have to start aspirating the tube, see whether the tube is in place, whether gastric contents is there or not, whether the before feed is leftover is coming out, whether the patient tolerated food, feed or not. No, every secondarily, if you aspirate within 2 hours, none of the patient will digest their feed. They need time. So it doesn't mean that we have to aspirate every secondarily. As per the new guidelines, every 4 to 8 hours, we have to aspirate and see if the residue, if the aspiration amount is coming less than 200 ml, we can give the feed. If it is more than 500 ml, if the moment you are aspirating the Ralston feed, you are getting 500 ml at a time in the syringe, then withhold the feed for that particular hour, inform the doctor and document the same. Next slide. Now, as we have covered from the patient, from the time we receive, how to assess the history, medical history, assessing from the systemic, like from head to toe, understanding at the bedside, what are the things we have to monitor. As I have said, it is for the anticipation. We have to anticipate the things before it happens, so that timely action can be taken. Other than those parameters related to the patient, there is something which we will be doing other than at the bedside. So, timely blood sampling and collecting the lab values. Why blood sampling we are telling? Because any patients in the ICU, there are so many parameters helps in taking a decision for the doctors in treating a patient and planning a treatment. So each one should know the process of collecting the samples by using correct techniques. It is mainly applicable when we collect the samples from the central line and from the arterial for the arterial blood gas analysis, ensuring we are following a hand hygiene, cleaning the connectors with the alcohol swab, collecting the samples without any air in the samples, and flushing the line without any air bubble in the line. And it plays a vital role in taking key decision for the patient treatment and helps in early detection to prevent complication. Like example, we have taken a ABG. So it doesn't mean that we have taken a ABG, we have taken the report and given to the doctor. We should have some knowledge on the normal values of ABG, like pH is this much, PCO2, PO2. The moment you say, you can also understand, okay, my patient is dropping in this, he's not maintaining his PCO2, his bicarb is low. So immediately when you give the report also, you will communicate the same thing to your doctor. Doctor also communicate the same thing. Yes, this patient requires this, so he will order, he will have the plan of treatment, he will give the instructions. The instructions will be carried out in time with the coordination with the doctor, when we understand the importance of these specific blood sampling. Lab values need to be informed to the doctor. All should have knowledge, as I have said, on the normal range of important blood tests, which helps the nurses to communicate, as I have told, with the doctor, and we can participate in the decision making along with the doctor, and it in turn affects our knowledge. Next slide. So role of nurses during consultant rounds. So we will be thinking, okay, this patient I have assessed, patient was having this. So all these things we are assessing. It is not up to us to keep with us. We have to let it out, give our output, communicate to the doctor. Sir, when I came, this was the thing with the patient. When I saw the line was like this, there is some sort of redness. Patient is started having grade 1 of skin pressure injury when I turned the patient. So something can we do? So give your inputs, give to the doctor, help in taking the key decisions for a good patient outcome. So you have to have a suggestions for improving patient care, communicate, then it in terms gives a quality outcomes to the patient. And we are bridging the gap between the patient, family and the doctors. As I have told, 24/7 we are at the patient. We understand the patient from the top to bottom. It is our responsibility to communicate each and everything to the doctor when he come for the rounds, whether it is a small skin redness, small sort of infection, any change in the lab values, any drug which you feel that something need to be seen, any line which is crossing more than 7 days, 8 days, there is a signs of infection, line is not going properly, any lab value, like I've told, if the patient is on constipation, why feeding was not started. These are all questions will come out when we have a proper assessment by complete monitoring. continuous examination assessment. So these all helps in having a good patient outcome. Next slide. Next slide. So patient education. Why patient education is important when the patient is in critical area, like patient is in ICU, patient may not be conscious, patient may be conscious, but still we have to educate the patient, if not the patient, to the patient family, because they're leaving the patient in the ICU. They're somewhere, waiting somewhere else, understanding that patient has been taken care well. So it is the right of the patient or the family to know the condition, to understand what is the treatment is been going on in the ICU. And it is not a individual person decision, it is a multidisciplinary team, because it includes the consultants, doctor, nurses, physiotherapists, dietitian, social worker. All the team plays a vital role in educating the patient and family about the patient outcome. Next slide. Before slide. Yeah, nursing handoff and SBAR. We have done so many things from the starting of the assessment, systemic approach, then having the lab values, informing the doctor, accompanying the doctor in the rounds, informing whatever we have observed during our assessment, carrying out the doctor orders, following the instructions, checking the patient outcome. All these things will finally end up at one time when we leave the shift. Like I came at 8 a.m., I will be going at 2 p.m. So there are 101 things happen from 8 to 2. Where am I documenting? Where am I communicating to my next shift nurse, so that there is a continuity of the patient care which helps in a good patient outcome. So to maintain this continuity of the patient care, we should have a nursing clinical handoff. So from when and where we have to follow. It will be followed, applicable from one shift to another shift, like from the morning to evening, evening to the night. Then patient transfer from one area to another area. Maybe we have done everything in the ICU, patient has stabilized well and good. We are shifting the patient from the ICU to the room. So the ward nurse should understand what was the patient condition in ICU, what are the things we have done, so that everything need to be reflected in the nursing handoff. Not only that, during when we shift the patient from any procedural area, like from the ICU, patient may go to the operation theatre for any surgery, or maybe endoscopy, to the MRI. So we will be accompanying the patient, but still we should know what we have to communicate to those area where the patient is being taken care for next 1 hour or next 1 day or 24 hours till the discharge. So that will only happen in a structured format of SBAR. Next slide. I'll just brief you what is SBAR. It is situation, background, assessment and recommendation. As we all know, what is a situation? We will be introducing, identify the patient, tell about the general condition of the patient, whether it was good, fair or the poor or critical, and tell about the level of the consciousness of the patient. Comes to the background, whatever is going to the patient, it may be IV fluids, vitals, any lab value, any test you have done, any procedure done at the bedside, whether the patient is on any lines, ventilator, any drains, all these things has to tell about, come from the background. Then assessment. Assessment, already my first all slides said about the assessment. Assessment is our vitals, temperature, pulse, respiration, blood pressure, SpO2 and any other, like patient may be on CPAP, BiPAP, ventilator, if the patient is on oxygen, if the patient is having GR based monitoring, like our glucose random blood sugar, our glucose level, if the patient is diabetic, have we assessed the pain score? Sorry. So all the assessment which we are carrying out in our regular shift, those assessment need to be reflected in your handoff, saying that I'm writing now, pulse was 120 when I'm giving handover to her. So during that time, anything related, morning patient had a pulse rate of 140, so inform the doctor, so and so medication given, now patient is okay. This is what, when you are writing, simultaneously giving handover to the next shift who is taking care of, who will be taken over for the next 8 hours of the shift. Then recommendation. Any recommendation would you like to tell to the next shift? It may be risk of the fall. Is there any risk for the patient? Any risk of the pressure ulcers? So if the patient had scored high in the Gradings scale, so for sure every second only we have to turn the patient, assess the skin side. Patient is having some incontinence, so we have to turn the patient and see so that patient is not developing any. And you have observed patient complaint of some pain in the IV line. So you are going to tell patient has complained of some mild pain in the IV line, but there is no redness, there is no signs of phlebitis. But you are recommending to that next shift, they're saying that so and so patient has complained. Kindly make sure if it is there or assist if it required, the cannula can be changed. If any bowel incontinency, activities of the daily living, any elimination needs, what is the diet patient is on, any other specific things which you want to tell to the other nurse, we have to document and we have to put the date, sign, and the name. Next slide. Thank you.
Thank you, BhagyaLaksmi garu. It was a wonderful virtual experience. How a critical care nurse should monitor a patient in ICU with respect to patient parameters like head to toe, and with respect to other monitors and gadgets bedside. And lastly, how critical care nurse should deal with blood samplings, and a good communication is required. So there are actually few participants have raised their hands during your talk. I think if they, before going to MCQs, can they ask if they want? I'll just speak out the names. Divya. Participants can ask their questions if you want. Divya, Anila, Malati, Vaishali. Please unmute yourself and ask questions. Anila, can you want to ask question? Malati? Before asking questions, please unmute yourself and ask the question. Almost 100 participants have participated very well. Okay, then I'll go to MCQs. Just sharing my question. Participants can answer the question directly, or they can put the answer in the chat box, whichever is convenient to them. So coming to first question, which of the following is not a component of fast hug? The right answer, Kezia has answered this question. It is a secretions. What S means then? S means sedation. Yes, right answer. It was answered by many, like Mariam, Divya Raj. Okay. So coming to next question. Stucking. Screen is getting stuck actually. Which of the following is not a component of CLABSI bundle? Aseptic technique, daily review for need of line, intact dressing, alcohol of decontamination, changing, dressing daily. Yeah, Sarika and Sumati have answered rightly. So there is no need to change the dressing daily. As BhagyaLaksmi garu wonderfully explained, we need to change the dressing only when it is not intact or if there is any soiling. Many of you answered right. Maximum score in GCS? Yes, many of you answered. Pratyusha, Saraswati. It is easy question, basically 15. The importance of GCS is very much important. Any patient in critically ill admitted in ICU, we need to monitor the sensorium regularly in respect to GCS, especially traumatic patients with head injury. Based on the GCS only, doctor will be taking a lot of interventions, whether this patient needs conservative management or he has to go for a surgical intervention. Coming to next question, behavioral pain scale is used for assessment of pain in which set of patients we use this scale? Awake non-ventilated patients or ventilated patients, can be used on both or none? Yeah, Nitisha has rightly answered. Narendra. Basically, behavioral pain scale, we used it in ventilated patients who cannot communicate. Which of the following is the cornerstone in preventing spread of infections in ICU? Which of the following is the most important aspect in preventing spread of infections in ICU? Is it infection control policy or disinfect and keep surfaces clean or hand hygiene? Yeah, many of you answered correctly. Kezia, Pratiksha, Leena. Wonderful. So basically hand hygiene. WHO have stressed about the importance of hand hygiene in preventing cross infections in ICU. So basically 6 steps and 5 movements. It has to be followed by everyone who are touching the patient and surroundings. This is a little bit tricky question. Which of the following drug is not used for sedation in ICU? Yes, please. Which of the following drug is not used for sedation in ICU? Yeah, Hemant has answered rightly. Atracurium. Basically, we use all these drugs for sedating the patient, but atracurium is a muscle relaxant. It is not a sedative drug. So most of the time, sisters, what they do before giving any sedative drugs, they give atracurium simply to calm down the patient. Basically, it's a crime to give atracurium without giving any sedative drugs like fentanyl, midazolam, propofol. If you give atracurium, patient will be able to feel the surroundings, but will not be able to move. It's like a choking sensation. So every critical care nurse should keep in mind that before giving atracurium, they have to sedate the patient. So the right answer is atracurium. Modified Morse risk assessment is used for sedation assessment or pain or fall risk or pressure ulcer risk. Yes, many of you answered rightly. Ruth, Ruby, Sririka, Nishita. It is basically used to assess the risk of fall in an ICU. Following are monitored for hemodynamic assessment. All of the following are monitored for hemodynamic assessment in ICU, except which one of the following is not useful hemodynamic assessment? Heart rate, blood pressure, capillary refill time, urine output, sensorium, none. You have answered capillary refill time, you have answered. You have answered sensorium, but the right answer is none. So basically all these parameters are useful for assessment of hemodynamic monitoring. See, heart rate is, we use heart rate, blood pressure, capillary refill time is useful, urine output is useful, even sensorium is also useful. If a patient is having hypotension, he'll be drowsy. So the right answer is none. So anyone have doubts? You can ask directly by unmuting yourself, or you can put in the chat box. Any participant want to ask question to BhagyaLaksmi garu? Yeah, there is one doubt in the chat box regarding the head-up position. Madam, a patient with an unprotected airway fed by Ryle's tube, but throwing intermittent seizures and started on antileptics, still throwing fits, flat or head-up tilt, madam. BhagyaLaksmi garu, the question is that a patient is in head-up position with an unprotected airway and he is having a seizures. And the patient is started on anti-epileptics. Still the patient is throwing seizures. We should keep the patient flat or head up. Do you want to take this question?
For any patient, sir, if the patient is having the seizures with an unprotected airway, the primary thing which we'll be doing is putting the patient in the side lateral position. It in terms prevents the aspiration. So during the feeding also it is feasible to put the patient in little sideline position and give the feeding. And especially when the patient is having continuous ongoing seizures and with an unprotected airway, how far the feeding can be indicated, that if sir answers, that will be.
Yeah. So what is the right? The patient is flat, we should immediately turn to one side position, and we should give the antiepileptic medication. Still the patient is having seizures, we should do a little bit head up, and our prime motto should be to control the airway. If still there is a chance of risk of aspiration, we should try to protect the airway by intubating the patient, keeping on ventilator. There is no point in simply changing the position. The patient is still throwing the seizures and his saturations are decreasing. Yes, please, any participants have a doubt? They can ask by unmuting themselves. Like initially, Anila, Malati, Divya, they have raised their hands during your talk. I have one question, BhagyaLaksmi garu. So with your immense experience and knowledge, what are the common mistakes usually bedside sisters do when they're taking care of patient with respect to lines, with respect to central line, artery line? So in your experience, what are the common mistakes you see?
So to say it is not mistake, it is just a lack of awareness and continuous training. Like if we train them continuously, 100% with a proper vigilance onto them. So if to tell in handling of the lines, we tend to not follow 5 moments of hand hygiene. Even if you do the hand washing steps, if you fail in any one of the moment of hand hygiene, there is a chances that patient may land up in infection. And using of a unsterile gloves when we're handing a line, which is a sterile. So those things, if you more focus in terms of hand hygiene, the things can be in control. We can prevent the infections.
Yeah, nicely said. So basically, hand hygiene has to be stressed a lot. Even doctors also sometimes when they try to deal with the lines, they forget to do hand hygiene. So the critical care nurse is entitled to stop even the doctor. They're not following proper hand hygiene techniques. There one participant named Vipul Kumar. He has just posted a subsequent question. If the patient is having a cervical injury and still is having seizures, can we give him a lateral position? So no, if the patient is having a cervical injury, we should not give him a lateral position, because our first and foremost importance is that we have to stabilize the cervical spine. So keeping a patient in lateral position, we may compromise his cervical spine and may further cause further deterioration. So we cannot give a lateral position to that patient. If at all, if you want to give a lateral position, then first we need to put a collar, hard collar, or stabilize. It is an emergency, stabilize the patient. Basically 2-3 persons will be required. One person has to stabilize cervical neck, and then he can give a lateral position.
So can we use log roll position for these patients when it is really required?
Yeah,
Stabilizing the cervical.
Yes, we can use it. One more question, BhagyaLaksmi garu. Madam, do good peripheral lines with no redness be changed if they are working on day 3 or later? Can you answer this question?
As per the new guidelines of the CDC, the cannulas need not to be changed if it is really working without any signs of phlebitis. And one more, if it is indicated, we can continue, and we have to understand if it is not indicated, if the patient is no longer is having the use of IV line, it can be removed. It doesn't mean that it is not having redness, we can put it on. If it is not required, we can remove, and if it is working well, there is no restriction of the days, we can continue till we need the cannula, till the patient is having any signs of phlebitis, or if the cannula is not working.
Okay, nice. So one more question, BhagyaLaksmi garu. So most of the times we see that when the doctors do rounds, critical care nurses, they're hesitant in communication with doctors. So until unless we ask them, they don't communicate. So what do you think is the main reason? So where is the lacking point?
So there is no lacking. It is like maybe to say work pattern, what they're facing in the ICU because of the critically ill patients and the monitoring technique. And if possible, the doctors can involve us in having a case presentation so that the people will become more confident in communicating what they actually need to communicate towards the doctor, because those inputs from the doctors can help us in communicating how we are presenting the case. So if that can happen, we can easily build a confidence in the staff, sir.
Okay, yes, thank you, BhagyaLaksmi garu. What I see is that most of the, especially in sisters who are very new to the ICU, they lack a little bit confidence, I guess, because they fear if they tell something how a doctor may respond. So the one most important aspect is that every critical care nurse should have a good confidence levels to communicate with the doctor. So that's what I feel it's very much important. Nicely explained. Yes, any participants, they have any more doubts? Okay, so we shall end this session. Okay,
Sir, I would like to thank you once again for giving me this opportunity for ISCM and for Apollo Hospital and for ma'am, and especially to you for moderating this session in such a wonderful manner so that each and everyone has participated well. And those answers of the participants can really reflect that they've understood the session completely. So thank you so much, sir, once again. Thank you.
Thank you, BhagyaLaksmi.
And thank you.
Yeah, yes. Thank you, BhagyaLaksmi. It's my pleasure to moderate being a speaker like you. So I thank ISCM for giving me this opportunity for participating in this training session for nurses. And thank you very much. And one last question was there actually. One participant was asking the picture clock, it means, with regard to position changing in ICU patients. I think we can get in Google or what, no? That picture, position changing in patient.
Yes, we can get it by us, whichever position you want, like especially during the food timings, like the patient breakfast or the dinner or lunch. So those timings we can make the patient in the supine, like patient may be in the follower's position. Rest timings we can split whether the patient can be the right or the left lateral position. So it can be built by us.
One participant has asked, can we get this presentation? No, this presentation will be uploaded in the Facebook and YouTube also, I guess. So, okay, Dawal, can we end this session? Are you there? Okay. Thank you very much. Almost nearly 100 participants are there for a wonderful cooperation. We'll end this session. Thank you very much. Thank you all.